Hey folks, Scott Weingart here, and this is the EMCrit podcast. Now, I promised you that this was going to be the time I was going to introduce Rush 2.0, the rapid ultrasound for shock and hypotension. I'm going to delay that one podcast period because a lot of stuff has come out in the past few weeks that I don't think it would be timely to wait. So I really want to hit those today. So that's what I'm going to do. This podcast is going to be dealing with a few things, including Arise fluids, some Bicarb studies, and a couple other stuff. And then next time I will hit the Rush 2.0. Hopefully that is not disappointing. Now, before I get in, super quick, we have our Unburnable cohort number 5 coming up in September. And I'd really like to get a few more people into that course because it is extraordinary what the level of burnout for people coming in versus the level of burnout of people coming out of that course. People are happier. People are excited to go back to their shifts. They find joy again in their career. And I'm not stating that based on my own subjective impression. I'm basing that solely on the reviews and exit interviews of people that have taken the course. This will walk you through inner voice, agency, how to get sleep, how to get joy during your shifts, efficiency, so much communication. I love this course so much. I love teaching it, and I think you will love being in it. So if you're interested in that, come to Unburnable Course, all one word, unburnablecourse.com, and check it out. All right, let's dive right in. Recently, the Critical Care Reviews 2026 meeting occurred, and this is the work of Rob McSweeney, and it is just an astoundingly good conference. I've never attended in person. I just watch the freely available live stream or edited videos that come out. And he's just doing such an extraordinary job, as is his team. Rob, I think you should be truly proud of what you have wrought. It is a boon to the critical care community. It is now where many critical care trialists want to debut their trial results. That is an extraordinary accomplishment, and he just does such a good job with the format of the conference of highlighting these trials and really giving you the time to dig in and understand it from the basis of smart people in the field, of the trialists themselves, of methodologists. It's amazing. I'll link to the Critical Care 2026 Critical Care Reviews meeting on Vimeo, and you can check out any of the papers mentioned in this podcast there as well if you want more information. The first, and I think the most important trial that came out of that CCR 2026 meeting is the Arise Fluids trial. And this came out of the Arise Fluids group as well as ANZIX and the ASEM organization, and it is so fucking good. This is the exact trial I needed. And obviously, I'm biased in my judgment of how good this trial is because it answers the exact question I needed answered in a randomized controlled trial. And it is just so well done. Okay, so what was this? This was a open label, multi-center, randomized controlled trial done in 51 hospitals across 3 countries in both EDs and ICUs. And what they did is they took patients in septic shock by the sepsis 3 definition, so that means they were both hypotensive and had a lactate greater than 2, who had already received between 1 to 2 liters of fluid pre-randomization. And they randomized them to 2 groups. Let me give you a little bit more about the P, and then we'll go into the actual interventions. So these were adults, as mentioned. They had a systolic blood pressure less than 90 or a MAP of less than 65 after at least 1,000 cc's of fluid, and that included pre-hospital fluids. They had the blood lactate greater than 2, and they had already received their first dose of antibiotics. The exclusions: they could not have received more than 2,000 cc's of fluid. They could not have had 6 hours have elapsed since their ED presentation, and clinicians felt it was okay to enroll them, meaning if a clinician felt either arm of the treatment or either intervention group was inappropriate, then the patients were excluded, which means for a trial like this, if the clinicians said, these patients are already fluid overloaded, I don't want to randomize them to the profligate fluid group, they were excluded. If they felt they were severely dehydrated and didn't want to randomize to the fluid restrictive group, they were excluded. So just keep that in mind. And then if there were any barriers to intervention, like the patient had to go to the operating room right away or things like that. So they randomized 1,037 patients didn't consent, so their intention to treat population, 963 patients. That makes this a big trial when we talk critical care. Biggest to date for this kind of fluids trial. It is exactly what we needed to really get a degree of precision that we needed to make the results of this trial, in my estimation, inarguable. Okay, so what did they actually get in terms of pre-randomization fluid? Both groups got precisely, as a point estimate, 1,500 mLs, which was 18 mLs per kg. So that's what they got at the baseline. Now, some of the people at the meeting were commenting, was that too much? And maybe for other purposes of analysis, but for the purposes of mine, you know my lens. You know exactly how I'm looking at this trial. I am saying to myself, will this finally disabuse the surviving sepsis campaign folks of 30 mLs per kg being an evidence-based treatment intervention? And so I was absolutely fine with the 18 mLs per kg pre-randomization in both groups, because my contention has always been the surviving sepsis recommendation should go back to either 20 mLs per kg as your initial fluid resuscitation, or 20 to 30 I'd be fine with. 20 to 30 gives me the latitude, the range to do what I think is right, which is somewhere around 20 mLs per kg. And it still allows the people that believe more fluid is better to give 30. So that's what they should have written, 20 to 30. So 18 pre-randomization, I am absolutely fine with. 1,500 cc's in both groups, 18 mLs per kg. All right, then what were the two interventions? Well, the two intervention groups. The intervention group 1, the vasopressor group. This is a fluid restrictive group. What happened to these patients? IV fluids were stopped immediately. Vasopressors were started immediately, because remember, these patients were below pretty much anyone's MAP goals. You were allowed to give fluid boluses of 250 mLs if the patient was in refractory hypotension, they had persistent hypoperfusion, for instance, delayed cap refill, their lactate was greater than 4 or rising despite 2 hours of resuscitation, they were persistently tachycardic, or they were oliguric. They had a 0.5 mLs per kg, less than that, for greater than 2 hours. Reasonable. I'd argue a lot of those, you still didn't need fluid, but very reasonable. Got no problem with it. They discouraged maintenance fluids, and the intervention was delivered for a minimum of 6 hours, or they kept going for 24 hours of the intervention if the patient was in an ED or ICU and therefore could be receiving monitored care. So that's your vasopressor group, a fluid restrictive group. They basically told them, don't give fluids unless you have to, you really feel the patient needs it. The control group, the fluids group, they were fluid encouraged. So they got an additional up to 1,000 mLs within the first 60 minutes after randomization if their MAP was low before starting vasopressors. Obviously, if the patient's BP plummeted, they were allowed to, but that was the recommendation, is try to give them a more aggressive fluid load before you start vasopressors. You could give additional 500 ml boluses for persistent hypotension or hypoperfusion. They strongly recommended the 30 mLs per kg within the first 3 hours of ED presentation as per the Surviving Sepsis Campaign guidelines. So they really were trying to make this the Surviving Sepsis Campaign group. Fluid type, responsiveness, assessment methods, maintenance fluid, and MAP were at the clinician's discretion. Vasopressors were initiated if the target MAP was not achieved and the patient was deemed fluid euvolemic, or the BP was unresponsive to fluids. If the patient was already on vasopressors at the time of randomization, they did not mandate stopping them. All right. Then for common care to both groups, it's all the stuff expect in a pragmatic trial. Usual care, ancillary interventions, patients assessed were hourly in both groups for up to 6 hours and then as appropriate. And if their hypotension became critical, then either group could get fluids and vasopressors. All right, so what actually happened? I'll put the intervention type stuff in a table in the show notes. The one I want you to understand, again, based on the lens that I'm looking at this for, is within the first 6 hours, the vasopressor group, the fluid restrictive group, got an additional 500 mLs on average. The fluids group got 1,500 mLs in those first 6 hours. So we had 1,000 cc separation. And that about 1,000 cc's continued if you looked at the 24-hour mark. So really the difference, the separation, was in those first 6 hours. So if we put that in mLs per kg, in the 6 hours after randomization, the patients in the vasopressor group got 7 mLs per kg additionally, and the fluids group got 20 mLs per kg additionally. What does that really mean for what I care about? Looking at this through the lens of the Surviving Sepsis Campaign guidelines. So the total fluid received in the first 6 hours. In the restrictive group, 25 mLs per kg. In the fluids group, 38 mLs per kg. This is perfect. This puts us right in the sweet spot. Would it have been nicer if they wound up at the 20 versus 30? Sure, but I'm fine with this. 25 versus 38, it's fine. Because again, it's in that 20 to 30 ml per kg range that I care about. So what was the primary outcome? Exactly the same between both groups. 76 days alive and out of hospital at day 90 in the intervention group and in the control group. Exactly the same. For secondary outcomes, no real difference. In terms of safety outcomes, pulmonary edema was 0.6% in the vasopressor group and 5% in the profligate fluids group. So significant difference there. Small numbers, 3 patients versus 24 patients. But there was potentially a harm outcome. I don't think those patients really did badly as a result of their pulmonary edema. So I wouldn't make too much of that. So what does this mean? Both intervention strategies are safe. Both give you identical outcomes. Therefore, there should be no performance measures that force you to give 30 mLs per kg. There's just no evidence for it. We have now evidence of equivalence that I think is inarguable. I think Clover's already pointed us there, and this one really finishes off anyone claiming the 30 mLs per kg is evidence-based. We need to stop it. It doesn't make any sense. And I've already written to the chair of Surviving Sepsis Campaign. I have not received a response yet, but if anyone from the Surviving Sepsis Campaign is listening, the truly evidence-based move right now would be to put out an interim statement saying, based on this most recent publication, we are changing our fluid recommendations to 20 to 30 mLs per kg in most patients. There will still be patients who are exceptions to that and may need more or less, depending on clinician judgment, but 20 to 30 is very reasonable for most patients. It's also of interest that the Australian and New Zealand's, which were the predominance of the centers in this trial, who have always been more fluid careful than I think other parts of the world, have moved towards a more liberal use of fluids. The 1,500 mLs by the time of randomization completion would tell me that they're a little bit more fluid liberal. And so I think that's where we've all moved. And I don't want the pendulum to shift too far the other way. I think we're in a really good place in sepsis where people now understand that you really should be giving a modicum of initial resuscitation with fluids to every septic patient, even with pre-existing medical problems. I think we shifted a little bit too far with the 30 mLs per kg. We certainly come a long way from the insane dousing of fluids from early goal-directed therapy. I think we're getting into a really good place here. And that really good place is, in my clinical opinion, somewhere between 20 and 30 mLs per kg. All right, read the trial. Fantastic. Watch the video on the CCR26 Vimeo. It's all good stuff. All right, let's do a palate cleanser before we get back to the CCR26 trials. The non-surgical management of traumatic pericardial tamponade. And this one made the rounds of the various social media outlets on X and Blue Sky. There were numerous blog posts about it, and this was pericardiocentesis drainage and instilled TXA definitive management in a 25-case series of penetrating cardiac tamponade. It was published in Injury 2026. And this came out of the... Oh, do I hate that sound? I know you hate that sound, but that is the sound you hear at the end of a paid episode in which you only get partial content. And that's because you're not a member of EMCrit. You are not an EMCritter, which means you're not getting all of the up-to-date critical information to help your super sick patients. Whether you're in the ED, ICU, or the pre-hospital environment, EMCrit will help you take care of your patients better. It's cheap. It's tax deductible, or you could get it reimbursed on your CME, and you're part of something bigger than just this content. You're part of the team, and we're going to have so much incredible stuff coming out in the next year. New things, new episodes, new forms of education, and you're not going to want to miss out on it. And while there is a ton of foam, there's a bunch of stuff that is behind the paywall. So please, please consider joining. Just come to emcrit.org/join. It takes 2 seconds, and then you will never have to hear this message again. but more importantly, you will be getting the cutting-edge information to take care of your super sick patients. Scott Weingart for the EMCrit podcast saying bye-bye, and please come on over to emcrit.org/join.